Okay, so my name's Anisha. I'm an F1 and welcome to Essentials of Dermatology. Essentially, this talk is going to go through, cool, you can hear, the reasons why we started it. So basically, I think during med school, most of us, if we had dermatology teaching, it was probably some random Zoom lectures. And if you're like me, I didn't really focus during Zoom lectures. So now, as an F1, when I come to do derm referrals, it's extremely awkward and I'm kind of clueless. And unless I'm saying the terms red maculopapular rash, I don't really know what else I'm saying. So basically, it's going to be a building block for further dermatology learning. And what me and Shaz want to do with Mind the Bleep is do a whole dermatology series where we'll cover loads of interesting topics. So psychodermatology, artificial intelligence, just any kind of condition. So this will kind of be the building block for that. So contents, next slide. So I'm going to start with some skin functions and facts, a quick reminder as to what the skin does, looking at the gross anatomy, and then we'll move on to taking a history, doing an examination, and then key part is how to communicate all your findings, which is what probably most of us don't really know what to do. Next slide. So skin functions and facts. So it's the largest organ in the body. It's 15% of human body weight. And it's quite an externally dynamic organ. So you have a constant turnover of cells and a cycle of renewal and regeneration is about 40 to 60 days. That's probably meaning that about half the dust at home is probably just your skin. And the reason I really like dermatology is because the skin reflects kind of the internal state of your organs, kind of like a canvas is how I like to think about it. So a couple of examples would be the more obvious SLE, butterfly rash, but then you have the more subtle inflammation of subcutaneous fat, which you find with erythema nodosum, commonly seen in inflammatory bowel disease. Next slide. So the skin has a multitude of functions. So first of all, we'll talk about protection. So quite obviously, it gives us protection to mechanical forces. So the subcutaneous layer of fat literally acts as a shock absorber to trauma. Then we'll get quite a literal mechanical barrier from microbes, chemicals. And then another aspect of protection would be protection from UV damage. So the pigment melanin, which protects our DNA, and it's why in reaction to light, we tan, because we're essentially increasing melanin production. And then the skin also regulates our temperature. We've got arterioles and our dermis, which respond to temperature through dilating and constricting. And we also have equine glands, which when it's hot, produce sweat. And then that leads to convection, taking away that heat energy from our bodies and we cool down. And then the skin also contributes to metabolic regulation. So keratinocytes in the skin produce vitamin D, and that contributes to calcium homeostasis. And then we also have the immune function from Langerhans cells, which are dendritic cells in our skin. And then something that you might not think about a lot is the skin helps us choose what to absorb and what to secrete. So obviously we secrete things like sebum, but then also things like patches, so nicotine patches, estrogen patches. Our skin is essentially a gateway of what's going in, what's going out. Okay, next slide. So skin thickness varies based on anatomical location, age of a patient, and sex of the patient. So the epidermis tends to be thickest in your palms and your soles, around 1.5 millimeters, and it's thinnest on the eyelid and the ear. Next slide. And the dermis tends to be thickest on your back, and quite obviously subcutaneous tissue is thickest in places like your abdomen and your buttocks. And generally the outline of skin thickness is it's more thin in children, it then thickens whilst you're reaching your 30s and your 40s, and then it thins out thereafter. And generally, male skin is about 20% thicker than female skin. And this is because the collagen content of male skin reduces at a more constant rate, whereas female skin, we're more affected by menstrual cycles, we're more affected by menopause. It's the relationship between estrogen and progesterone and collagen content. So particularly after menopause, that's when females tend to get more wrinkles, thinner skin in general. So just kind of the background of why male skin is more thicker generally. Next slide. So here we have a back to basics diagram of the skin. We've got the epidermis, which is just 5 layers of cells. Then we've got the dermoepidermal junction, which has the birth basement membrane. We then have the dermis, which is split into 2 layers, superficial papillary and deep reticular. And then we have subcutaneous tissue right at the bottom. Next slide. So the epidermis is made up of 4 major cell types. We've got keratinocytes, melanocytes, Langerhans cells, and Merkel cells. And they each have their own function, but they synergistically work as an organ to perform all those functions we talked about earlier. Next slide. So keratinocytes are the predominant cell type in our epidermis. They originate in the basal layer, aka the stratum basale, and that's the deepest layer of the epidermis. And they are keratin-producing cells. So keratins are the structural proteins found in our skin, hair, and nails. And essentially, they form that epidermal kind of water mechanical barrier we were talking about earlier. And they have a huge role in vitamin D synthesis. So essentially, when UVB light hits keratinocytes, it activates cholesterol precursors, and then we form vitamin D, and that feeds into the whole calcium homeostasis system we were talking about earlier. Next slide. So the next cell type to talk about is melanocytes. So you can see where the arrow is. You've got a little melanocyte sitting there in the basal cell layer of the epidermis, and it's sat between all the keratinocytes. And the reason for this is because of the mechanisms of how pigment is produced and subsequently transferred to keratinocytes. So melanocytes are dendritic cells. So they make melanosomes, which are basically spherical organelles which have the pigment melanin in them. And that's stimulated by UV light. Next slide. So interestingly, the difference in shade of skin is not caused by the number of melanocytes you have. It's the number of melanosomes which our cells produced. So in dermatology, we use the Fitzpatrick skin phototype scale to assess someone's risk of developing skin cancer. And that tends to depend on how light or how dark their skin color is. So I find it quite useful in referrals at the moment, as opposed to simply saying, okay, a Caucasian male or Asian female. I tend to just say, okay, type Asian female, type 4-5 skin. I just find it makes it more of a structured referral. Next slide. And I made my own celebrity Fitzpatrick phototype scale. So type 1, you're thinking more Taylor Swift, pale skin, tends to be blue eyes, always burns, doesn't tan. Type 2, you're thinking more Dua Lipa, still white skin, but a bit more darker, burns easily, tans poorly. Type 3, you're thinking more Kim Kardashian. So she's got light brown skin, which tans after an initial burn. Type 4, you'll be thinking more Zendaya, so moderate brown skin, burns minimally, tans easily. And then type 5, you're thinking more Priyanka Chopra Jonas, dark brown skin, rarely burns darkly. I'm probably somewhere between type 4, type 5. And then type 6, you're thinking Winnie Harlow. For those of you who don't know who Winnie Harlow is, she's a supermodel, but she has vitiligo. So she campaigns about her skin conditions in the public light. So I just think that's quite cool, having a model with vitiligo. And yeah, so she has type 6 skin, dark brown, black skin, never burns, always tans darkly. So next time you make a referral, just think about which celebrity your patient looks like. Okay, next slide. So back to melanocytes. I just think this is very interesting. So melanocytes have these melanosomes. They're melanin granules, which are transferred to neighboring keratinocytes through phagocytosis. So there are these long processes extended from the melanocytes, which kind of donate these balls of pigment to the keratinocytes. And this process is called pigment donation. If we move to the next slide. And it's just a really beautiful process. I've included some microscopy images. So at the top, at image A, you can literally see this pigment ball inside the keratinocyte, which have freshly undergone some phagocytosis. At image B, you can see a scanning electron microscopy image capturing the pigment just about to go into the keratinocyte. And then at D, you can see the long extensions I was talking about, where the arrow is. And E and F are just some simple microscopy photos showing, again, melanosomes entering the cytoplasm of keratinocytes. Next slide. So the next cell we're going to talk about are Langerhans cells. So these are mainly found in the stratum spinosum and I'll get to the layers of the epidermis later in case anyone's forgotten. And they're antigen-presenting cells, which activate T cells and help allergen recognition. So essentially, they play into the immunosurveillance role that the skin has. And they also are dendritic cells like melanocytes, but they're not connected to keratinocytes because they don't do pigment donation, essentially. And something I think is really interesting is that UV radiation actually decreases the number of Langerhans cells we have. And that partially explains the mechanism behind treatment for things like eczema and psoriasis through PUVA and UVB light treatment. It kind of reduces inflammation in those disease processes. Next slide. And the last cell we'll be talking about is Merkel cells. So they contribute towards the function of mechanoreception and that whole nervous system. And they contain specialized nerve endings for sensation. And of note, you can have a rare aggressive skin cancer called Merkel cell carcinoma. So you would classically find that in the head and neck of Caucasians, aka people with type 1 or type 2 skin phototypes. Next slide. Okay, so now I'm going to go into the epidermis and its structure. I don't know about you guys, but I went through this in year 1, year 2 of med school. Barely remembered any of it, but it's so interesting just to look back on, look through again, because it helps you kind of explain the disease processes with skin. And I just think it's a good foundation to go through as we're building forward in the series. So all the cells we talk about are positioned through the epidermis. Obviously, keratinocytes are the predominant cell. And essentially how the epidermis works is there's a constant migration of keratinocytes going from the bottom to the top. And as they move up, they mature, they flatten, and they lose their nuclei and they lose all their organelles. So eventually, by the time they reach the top at the stratum corneum, they're just flattened, dead cells. And that's how they form such a great barrier to the external environment. And this whole process is called keratinization. And I mentioned earlier that the whole process takes about 40 to 60 days in most people. So it's kind of like self-renewing exfoliation, which is nice to think about in the context of your own skincare or my skincare routine. So, you know, if you're using a new retinol cream, you're not going to have overnight results. You need to give it around a month or so because of the way the epidermis works. So next slide. Okay, so we'll start off with the stratum basale, which is the deepest layer of the epidermis. It's located just above the dermis, and it's made up of stem cells of about 10%. And it's the first layer of keratinocytes. So like I said earlier, the cells divide, they flatten, they mature, and they move up. And predominantly keratins 5 and 14 are expressed here. Next slide. The reason I brought this up is because you can get this awful genetic condition called epidermolysis bullosis simplex. And it's essentially when you get keratin mutations of 4 and 15, genetic mutations in keratins 4 and 15. And that leads to the skin being more sensitive and vulnerable to blistering on very minimal friction. And it's inherited in an autosomal dominant pattern. And you can get very severe forms which present at birth with widespread blistering. And because it can also affect mucosal membranes, you're also then thinking about how children are feeding, how it's affecting their nutrition. So things like feeding issues and characteristically hoarse cries when they're born, and that's because of blisters in the larynx. And as you can see, it's extremely painful. Next slide. So the next layer we'll be talking about is the stratum spinosum, which is the one I mentioned earlier when we were talking about Langerhans cells. So this is known as the prickle cell layer as well. And the reason it's called prickle cell layer is because you get these spiny kind of processes and bridges between the keratinocytes called desmosomes, and they kind of help to have the keratinocytes sticking together as they get flatter and as they move up. And thickening in this layer is specifically called acanthosis. That would be more relevant in kind of histology. And again, so keratins 1 and 10 are primarily expressed in this layer, and when mutated, they lead to a really horrible genetic condition called epidermolytic ichthyosis, which is on the next slide. So unlike EBS, which we mentioned earlier, epidermolytic ichthyosis the mutations from it are more sporadic. And if they're not sporadic, they're probably autosomal dominant. And it's like EBS, it's also got, widespread reddening, scaling, severe blistering, which becomes apparent at birth. And you also get some hyperkeratosis with it. And yeah, we'll come back to what hyperkeratosis is later. And it's just, I just thought I'd put those two diseases in just to highlight when you get an absolute breakdown of some of the core functions of these layers, it can lead to such a devastating picture. Just to contextualize going through the histology, I think it's quite nice. Okay, next slide. So on H&E staining, the stratum granulosum is that kind of deep purpley layer you can see there. And the reason it has that deeper shade is because there are these dense keratohyalin and lamellar granules. So what these granules do is they discharge their contents. They tend to have keratin precursors and lipids inside them. So they discharge them somewhere between this layer and the layer we're talking about next, which is the stratum corneum. And that produces this beautiful cornified cell envelope, which kind of it contributes to the lipid barrier we were talking about earlier. And thickening and stretching specifically in this layer is called hypergranulosis. So you see that quite commonly in lichen planus in histology. Next slide. And this is an intermediate layer. It's called the stratum lucidum, and it's only found in palms and soles. And it's just that thin transparent layer you can see in the middle. And there's not much else to say about this layer, just that it is present. Next slide. And then the final layer we're going to talk about is the stratum corneum. So this is the terminal layer of differentiation. It's got loads of interlocking dead stratum corneum cells. And the way we describe this layer is a brick and mortar structure. So the bricks represent dead anucleate keratinocytes, which are placed in a whole kind of array of lipids and proteins, which we mentioned in the stratum granulosum. And the relevance of this is that in diseases like eczema, you don't have as much of a strong lipid barrier. So the lack of moisture tends to dry out the skin a lot more, which is why you get more of an inflamed picture in something like eczema. And the thickening of this layer specifically is called hyperkeratosis. So it just means increased thickness in the stratum corneum. And it can be a cause of lots of different things. So typically things like chronic friction or chemical damage can lead to hyperkeratosis. So that's why the use of aggressive soaps can create that picture. Okay, next slide. So quickly, just to run through the DEJ, or the dermoepidermal junction. So this is the interface between the stratum basale and the dermis. And it's kind of the core of a structural support between the two, because it allows for epidermal renewal and regeneration, which is happening above, but it also kind of keeps that contact between the deeper layers. And typically you get root ridges. So you get downward projections of the epidermis, which lock into the dermis and kind of like an egg crate. And actually flattening of the DEJ enhances wrinklings really interestingly. So next slide. And then finally, we're reaching the dermis. So there's two layers, superficial and the deeper reticular. And the dermis is where all the adnexa are: sweat glands, hair follicles, neurons, blood vessels. It's all happening here. And the predominant cell type here is fibroblasts, which produce collagen, elastic fibers, and glycosaminoglycans. So next slide. So I just wanted to touch upon fibroblasts and aging. So like we said, fibroblasts make collagen, which in human skin, type 1 is the main one. In fetal, it's more type 3. And so it's, sorry, I think I made a typo there. So the dermis is basically made up of collagen and elastic fibers. So I put a little diagram there. You can kind of see all the collagen structures lining up, and then you've got elastin fibers with it, as he's pointing out, and it basically, this kind of matrix-like structure gives the skin that support, and that's kind of underpinning what we know as healthy skin. And it gives us a bit of firmness, it gives us that elasticity, but from kind of early adulthood, our collagen production reduces by about 1% per year. So kind of from your early 20s actually. And I just wanted to touch upon supplements. So if any of you ever have decided to take collagen supplements or thinking about it, it actually is useful. So hydrolyzed bioactive collagen peptides have been shown to improve skin elasticity, hydration, and visible signs of kind of wrinkles. And I've got just got a little diagram here just to show you kind of how deep wrinkling would work in the context of reduced collagen and reduced elastin. And you can see kind of the ages going from 20 to 70 with the wrinkling coming through. So I just think that's just quite a nice visual. And again, collagen production is affected by so many things. So one of them would be retinoids and vitamin A products, which upregulate the production of collagen. And also UV radiation downregulates collagen. And also I wanted to touch upon hormonal changes. So the decreased production of collagen after menopause just simply reflects the reduced estrogen and progesterone as well. And again, steroids, we know that skin thinning is a side effect of steroids, and that's just because steroids downregulate collagen production, which is why you get atrophy as such a prominent side effect. Next slide. Okay, and another product of fibroblast functions are glycosaminoglycans, and the one that we all know is hyaluronic acid. So HA is basically a humectant, which means it absorbs moisture from whatever it's surrounding. So that's what we associate with the plumpness and volume of kind of healthy, youthful skin. And topically, for any of you that use the humble, ordinary HA serum, topically it's a great moisturizer. You can put it on your stratum corneum, it'll give it some temporary plumpness. But like I said, HA and other glycosaminoglycans, they're mainly in the dermis, which is why you get HA used a lot in dermal fillers. So Juvederm is basically HA. And the reason it's so effective is because you inject it straight into the dermis where it kind of belongs, and it gives it immediately, it gives your skin a bit of volume, and it gives it that filling effect, which is why you can also see it in lip fillers here. So you can see that kind of immediate just volume, and that's from HA. Okay, next slide. Cool. So the papillary dermis is the thinner layer of the dermis, and it's composed of more thinner connective tissue, and it has the subpapillary plexus with all the arterioles that help for temperature regulation. And next slide. And then we have the deeper part of the dermis, which has thicker layers of collagen fibers, and it supports the adnexa in the skin. And next slide. So moving on to how to do a dermatological history. So simply start off by asking about the presenting lesion. So just general questions, when and where did the rash or lesion start? So the nature of it, the site of it, and how long has it been there for? And as with any presentation, if they are able to, let the patient describe the lesion to you. And then you ask about any associated symptoms. So I think there's mainly 4 that are kind of key for dermatology specifically. So pain, itch, bleeding, pus. Next slide. Then you should ask about whether there's any triggers or alleviators. So you can kind of tell we're kind of following more of a Socrates pattern, like for pain. And just ask, what makes the lesion worse, what makes it better. For example, stress can trigger a bad psoriasis flare. You might have a patient, planning their wedding and they've now got new flares of psoriasis. So clearly, stress is clearly a big factor for them in this situation. And then ask about medications. What are they taking? Have they started anything new? Because that can kind of lead to maybe an urticaria-like picture, especially for something like NSAIDs. And again, whether they've had any injury to any area of their body, is, even just a small scratch, is worth asking. So next slide. And that's because I just wanted to touch upon injury responses. So there's some really interesting ways the skin reacts to very minor trauma. So the first one is the Koebner phenomenon. I'm sure most of you heard of that. I feel like it comes up a lot on PassMed. So the Koebner phenomenon is just describing areas where you have new skin lesions on your skin where you didn't before in the context of pre-existing skin disease. So plaques in psoriasis or vitiligo, or patches of hyperpigmentation in vitiligo, you'd kind of see maybe Koebner phenomenon happening there. Whereas pathogy is something similar, but a bit different. So pathogy is more of a generalized inflammatory tissue response to injury. So it kind of forms papules and pustules. So it's not specific to any pre-existing disease. And commonly you can kind of get this in something called pyoderma gangrenosum, which I think is interesting. So I've put a picture of PG at the top, and then you've got hyperpigmentation patches of vitiligo in the middle, and then you've got your plaque in psoriasis at the bottom. So PG is essentially rapidly enlarging, very painful ulcers, and it is associated with inflammatory bowel disease. So just interesting. So those are the two kind of injury responses to look out for. Next slide. Okay, so then go on to asking generally about their occupation and social history. So do they smoke? Do they drink? Do they do any recreational drugs? All of which can flare and trigger certain conditions, and I'll come back to recreational drugs actually. And then ask about medications, allergies, and pets. So I mentioned earlier, NSAIDs can kind of induce a kind of drug like NSAIDs can induce lesions in the skin. And then we have travel and recent contacts. So ask, have they been anywhere recently? Have they seen anyone who's been on holiday recently? Just looking out for infestations or any tropical skin conditions, say Lyme disease maybe. And then also ask about COVID-19 vaccination history. So vaccinations can flare and trigger both existing and new skin rashes. So the vaccination dates and history is really important to note, especially in the current climate we're in. And then finally, ask about past medical history and do a quick systems review. So in terms of past medical history, I'm thinking more, say, in your atopic triad, you get people who have atopic dermatitis, but also are more sensitive to kind of allergic rhinitis and asthma. So it's just worth asking what else they have. And then for systems review, ask about systemic symptoms, so fever, weight loss. And then, as always, ask about your secondary dermatological sites. So these are hair, nails, and mucosal membranes, as well as joints. Next slide. Okay, so I wanted to touch upon the recreational drug side as well. So quite interestingly, there's this condition called levimazole, adulterated cocaine vasculopathy. And essentially it's induced by cocaine use. So you get this retiform net-like purpuric rash in patients who actually have to be anchor positive before, and then they might take some cocaine, which has been contaminated with levimazole, which is I think it's a pet drug, I think. If I'm wrong, I'm sorry. And then you get this kind of picture. So I just think it's interesting. It's always worth asking patients if they smoke, do they drink, do they do drugs, as awkward as it may be. Okay, next slide. And then lastly, a really, really important part of your history. I know we all learned ICE at medical school, but just, ask about how they are. Skin disease severity does not correlate with the psychological impact. You can have someone with a mild form of eczema, but who can end up so severely depressed. And on the other hand, you might have someone who has pyoderma gangrenosum, which we mentioned earlier, really horrible ulcer, really just not really ugly, but they could be fine. They might just have some mild anxiety, but it doesn't matter. You just have to assess the emotional impact that this skin presentation is having on your patient. And also because, skin lesions relate to, your self-confidence, your mood, your body image. It is really important. And quite recently this year, there was a parliamentary report called Mental Health and Skin Disease. So this has been around from 2020, and it's essentially kind of trying to push for more psychodermatology clinics. At the moment, I think we have only 6 in the country. And so, yeah, this was really recently discussed in Parliament this January, actually. So, yeah, it is really important. So just ask. Yeah, next slide. And then I just wanted to touch upon skin cancer specifics. So for skin cancer specifically, ask about the initial appearance and the evolution of the lesion. So has it changed? Ask if they are on any current treatments for skin cancer, and ask if they've had previous treatment or surgeries. Sometimes, having already been through surgery for skin cancer, the next stage might not be as effective, so it's worth asking. And then generally, in terms of kind of a social context, ask about their history of sunburn, use of tanning machines, their holidays as well. Have they had any long periods where they've been living in a tropical climate? And then, as always, ask about secondary dermatological sites, so nails, scalp, hair, and joints. And then, like I said, any previous history of skin cancer and family history. Next slide. And again, I just can't resist bringing up my celebrity Fitzpatrick scale. But I just wanted to touch upon this again because even though I have said, type 1, type 2, type 3, the lighter skin shades are at more of a risk of skin cancer, don't dismiss someone who may look like they have skin cancer with type 5 or type 6 skin. So kind of richly pigmented skin can also be affected, typically in acral areas. So don't dismiss a patient just because they don't have lighter skin. All of us can get skin cancer. Next slide. Okay, now we're going to move on to dermatological examination. So we know all the structure of the skin, we know what it's made up, to the histological level, we know how to do a history. Now onto the examination. So there's 4 principles, really easy. Inspect, literally look at the lesion, describe it, and I will provide us some tools onto how we do that because it's hard when you look at a rash. I honestly don't know what to say other than red maculopapular rash. And then P, palpate. So we'll come to that, and then do a quick systemic check. Okay, so next slide. So for inspection, start off with a general look at the skin. Look at the Fitzpatrick skin phototype, look at the number and the location of lesions, and look at the distribution and configuration. So configuration is just the outline of the lesions. Next slide. And then how to describe a lesion that you see. So we use a mnemonic SCAM. So S is for the size and the shape. So size, you can say millimeters, centimeters. C is for color. A is for associated secondary change. And I'll come back to how to differentiate between a primary lesion and a secondary lesion. M is for morphology and margins. And A, I've just added in there because we need to, again, do additional assessments for pigmented lesions. Next slide. So pigmented lesions. As we know, there's an ABCD approach to these. So A is for asymmetry, usually with something that's more cancer-like. Sides don't really match each other. Borders tend to be more irregular. There are different colors. Diameter of the lesion, if it's probably more than 6 millimeters, more likely to be more cancerous. And E, evolution. So as we went through earlier, as part of the skin cancer specifics in the history, ask about the evolution of the lesion. And I think patients are quite good at being able to tell if it's kind of increased in size. I think a lot of patients know kind of the ABCD approach, so they will kind of be able to answer all these questions. Next slide. Okay, describing the lesion. So primary lesions are any unmodified lesions direct from a disease process or birth. So I've got 2 examples here. So we've got strawberry hemangiomas at the top, which people are born with. And then secondary skin lesions are lesions which have evolved from that primary lesion. So this can be from trauma, infection, or medication, which you're taking for that primary skin lesion. So an example of this would be crusting from constantly scratching your eczema, an infective allergic wheal, and then lichenification of any epidermis. So the example I've included at the bottom there is atopic dermatitis, which has then been covered with lichenification. So that would be your secondary skin lesion on top of that. Next slide. Okay, here's the juicy part. We've done the entire assessment. We've been through history, we've done examinations, and I'm now going to run through how to communicate your findings into your referral. So we just never get taught how to do this in a proper structure. I feel like everything is quite sporadic. So I just wanted to run through some key words to use in a structure for you to work through the next time you see a lesion. Okay, cool. Next slide. So the first thing to look at, how to communicate morphology. So we'll start with primary lesions. So flat lesions are macules or patches. So macules are less than 1 centimeter. And an example of this would just be freckles. They're just macules. And patches are over 1 centimeter. So an example would be vitiligo patches, which you can see there. You can see a hypopigmented patch of vitiligo. And next slide. And then solid raised lesions. So these are not fluid fills. So we've got some papules. So papules are less than 0.5 centimeters. And an example of this would be milia. Plaques are over 0.5 centimeters and they have scaling. So obviously psoriasis is the first thing that pops into your mind when it comes to kind of scaly plaques. Nodules are more than 0.5 centimeters, but they have a more rounded, deeper component to them. So an example would be molluscum contagiosum, and they're more pearly nodules. And then, interestingly, a morbilliform rash is just a huge mix of macules and papules, and they tend to be from drug reactions and bug reactions. Okay, next slide. And then there's clear raised fluid-filled lesions. So these are vesicles or bulli. So vesicles are less than 0.5 centimeters, and a good example is contact dermatitis of the hand. And bulli are over 0.5 centimeters. For example, bullous pemphigoid or pemphigus vulgaris. Next slide. So I did just want to chuck in specialist skin tests because I think the differentiation between bullous pemphigoid and pemphigus vulgaris is quite confusing. So there's this test called the Nikolsky's test. So it's positive when on lateral pressure of unblistered skin, you get shearing of the epidermis. So if you rub an eraser on the skin, you're going to get shearing. So it's positive in, say, pemphigus vulgaris or estrate S, but it would be negative in something like bullous pemphigoid, which is more of a deeper disease process. And they're both autoimmune skin conditions. Next slide. So back to communication. Other lesions include pustules. So pustules are less than 0.5 centimeters, and they are like vesicles, but they have pus within them. Furuncles are caused by staph infections around or within a hair follicle. Carbuncles are just multiple furuncles, really. And wheals are transient raised lesions from dermal edema. So I included some examples there. So we've got some wheals at the bottom, and then we've got some folliculitis at the top. So you've got lots of pustules there building up. And this is actually really interesting. So this is a specific kind of folliculitis which you get at the nape of your neck and hair. Yeah, and you can see all that inflammation and all the pustules there. Next slide. And then a couple more words for secondary lesions. So excoriation is loss of epidermis following trauma. So like I said, how secondary lesions come from primary lesions. So trauma is another way of causing a secondary lesion. So if you're scratching lesions in eczema, you're going to get some excoriated, you're going to get an excoriated picture. A fissure is an epidermal crack, often from dryness. So, you know, when you get some hyperkeratosis in your feet, you tend to see that kind of dry picture with some cracks. Next slide. Okay, so lichenification is defined as well-defined roughening of the skin, and it basically accentuates skin lines. So you get that in things like chronic dermatitis, whereas scaling is kind of just flakes of that top layer of stratum corneum. You're just getting flakes of dead skin coming off. So you kind of see that in plaques in psoriasis, and you also get a thin plaque in pityriasis versicolor. So I put pityriasis versicolor at the top there. You can see that kind of thin plaque coming off. And that's quite different to psoriasis, where it's very obviously you can see scaling there. Next slide. And then lastly, or not lastly, there's more, crust. So crust is just a rough surface. It's basically made up of dried up sebum, blood, bacteria, dead cells from the top of the stratum corneum, which have basically come through. Yeah. Sorry, someone's just asked a question. You can get the slides later. So where was I? So you get dried up sebum, blood, bacteria, which have come through an eroded epidermis. So commonly from a burst blister. And the example I've included here is that classic honey-colored picture in impetigo in children. So you call that crust. Basically, you call that honey-colored crust. Next slide. And then ulcers and scars. So the definition of an ulcer is an excavation which reaches the epidermis, and importantly, it also reaches the dermis. So the reason ulcers heal with scarring is because you've hit the dermis. So we know that epidermis has that whole 40 to 60-day cycle of renewal and regeneration, but unfortunately the dermis doesn't have that, which is why you get scarring after. And scarring is just new fibrous tissue after healing. So you can get atrophic scars, which are very thin. You can get hypertrophic scars, which I put at the top there, which is basically hyperproliferation of the cells, but within the wound boundary. And then you can also get keloid scars, which go beyond the wound boundary. And they're a bit more difficult to deal with. And they're kind of more firm, more smooth, and they're more of a growth. And they tend to be quite uncomfortable for patients. Next slide. So the next step is palpating. So it's worth palpating any lesions your patients might have. So if you just kind of look at the surface or texture, is it rough? Is it smooth? Are the lesions elevated or are they depressed? So for example, elevated lesions would be, we mentioned earlier, the wheals in urticaria, where you're getting the dermal edema, so you can feel that on someone's skin elevated. Or if it's depressed, a common example would be hypertrophic scarring and acne. So I've got an example of that. If you were to put your hand over that, you can literally feel depressed lesions. So that's just a nice thing to comment on. Next slide. And then moving on with palpation, say with a nodule or a vesicle or a pustule, have a look at the consistency. You know, is it hard? Is it soft? Is there fluid inside? Is it solid? And then look at whether what you're seeing, is it moving? Is it on its own, or is it linked to any other structures? And then generally have a feel of it. Is it hot? Is it tender for the patient? Which would indicate some sort of infective or inflammatory process going on. And you can see the milia over there. You've got tiny, tiny dots of keratin, hard keratin. So if you touch that, that would be quite hard. And then molluscum contagiosum, you'd have more of a pus-like picture. Yeah. And then I've just got a picture of a cutaneous keratin horn. I just thought that's cool. So that would obviously be hard if you touched it. Next slide. Okay, last but not least, always do a systemic examination. So as we've mentioned multiple times, dermatology is not just the skin. Dermatology, includes scalp, hair, nails, genitalia. These are all sites to check. And an examination of other systems as well, just to check for any systemic disease, so SLE, IBD, thyroid disease commonly show up on your skin. Like I said, our skin is basically a canvas for what's going on inside. So just have a check. It's always worth doing. Next slide. And yeah, I just think nails are good to touch upon. So I just think there's an animation there if you just click. So you get pitting. So pitting is basically just punctate depressions of the nail plate. So you get that sometimes with eczema, psoriasis, or alopecia areata, which we didn't cover today, but we will do in later talks. Next slide. And next. Ankylosis is separation of the nail from the nail bed, which you can see at the top left there. So you can get that in psoriasis and, interestingly, chemotherapy as well. Next. Koilonychia is when you get spoon-shaped cells. So it's really classic in iron deficiency anemia, and you've got a really severe case over there in the middle. Next slide. And then obviously I had to mention clubbing, because clubbing is drilled into us through med school, but obviously, you know, it's part of dermatology, and classically you get it, you know, COPD, lung cancer, IBD, and Graves' disease, which are all things we also mentioned earlier when we're looking at skin lesions. So everything fits together very nicely, and it helps create a better picture for your dermatology referral. Next slide. Just touching upon vascular lesions, because I think they're quite confusing as well. So telangiectasia are small, superficial blood vessels, and of note, they blanch with pressure. So you can see them on a dermatoscope, and if you did see them, blanching them out would be called diascopy. So specifically, small vessels which blanch on pressure. Next slide. And then just to quickly differentiate some of the lesions we see in kind of more vasculitic diseases. So petechiae are less than 0.5 centimeters, and they're just extravasated red blood cells, and they're influenced by gravity. So they're more a result of platelet disorder rather than coagulation pathways. So you kind of see that in ITP. And the larger version would be purpura. So purpura is over 0.5 centimeters, sorry, not millimeters. And if they are palpable, that indicates some sort of inflammation going on, and there's edema within the lesion. And ecchymoses is a fancy term for bruising. And the reason we get that yellow color of a healing bruise is basically just the breakdown of hemoglobin into bilirubin. Next slide. Okay, this is my favorite mnemonic. So I'm aware I've kind of bombarded everyone with loads of different structures and ways to go about assessing your patient, from history, examination, and communication. But when you're actually seeing a lesion, it's really hard to immediately put all of that together without feeling like your brain is going to burst. And again, then you kind of slip into the habit of going, okay, this is a localized red rash. So less TCABs is a way of structuring all the thoughts you have going on in your brain. So L is for location. So when you're looking at the lesion, just where is it? Is it localized? Is it sun exposed? So an example of a sun exposed lesion would be actinic keratosis on the ear. So I've put a nice image there. So it's just worth checking. So scalp and ears, sun-exposed areas. Is it symmetrical? Is it dermatomal? So you've got an example of herpes zoster there, which is more dermatomal. E is for erythema. So that's just redness in and around lesions. Obviously, we all know that. Always comment on it. S is for surface. So now we've already palpated the lesion that our patient has. We can comment on that. So we know whether it's rough or crusted or scaly. So kind of a rough lesion would be, acne vulgaris, which are, you can see the kind of rough spots there. Next slide. And then T is for the type of lesion, so primary or secondary. It might not always be obvious whether a lesion is primary or secondary, so I wouldn't stress about trying to put that in a referral. C is for color. So is the lesion pigmented? If it is pigmented, you would have already done your ABCDE assessment and specific skin cancer questioning. Or is it hyperpigmented like vitiligo? And A is for arrangement, aka configuration. So if you have more than one lesion, how are they arranged in relation to one another? You can really easily comment on that. So your lesions might be generalized all over. They might be dermatomal. They might be ring-shaped. And I know we mentioned dermatomal earlier when we were talking about location. But again, it's just another reminder of things to comment on. B is for borders, so the demarcation of your lesion. An example would be differentiation between cellulitis and erysipelas. So erysipelas has more of a demarcated border, where cellulitis is more generalized. And S is for special sites. So how are the nails, scalp, genitalia, mucosal membranes, how are they affected? You can just quickly comment on that in the end. So yeah, less TCABs. If you just go through that, you will be fine for your referral. Next slide. And then I just want to really quickly run through some buzzwords for communicating, say, distribution. So generalized is quite self-explanatory, all over the body. Widespread would be even more so, even more extensive. Localized would be restricted to one area of the skin. And then flexural is looking in your body folds, so the neck, the popliteal regions, the antecubital fossa. So something like eczema, which is more of a flexural disease, you can see at the top there, that's more in the popliteal region. Whereas if you're getting lesions more in the extensor region, okay, for example, psoriasis is more extensor. Have a look at the knees, elbows, shins. So just you can comment really easily on distribution. And then obviously pressure areas, especially for most of us who are working in inpatient wards. So many of our patients are going to be having ulcers on, you know, sacrum, buttocks, heels. So just have a look at pressure areas. And then to communicate kind of maybe infection in the nervous system, you can really easily say dermatomal. And then a nice phrase for communicating lesions in areas more prone to skin cancer would be photosensitive. So I already showed a photo of kind of the ear helices. Yeah, next slide. And then how to communicate the arrangement of lesions. The discrete would be individual separated lesions. Confluent would be lesions which merge together. Linear lesions, quite obviously, are in a line. Target lesions would be concentric rings. So, for example, erythema multiforme, you can see on the hands there, you call those target lesions and you describe them as concentric rings. And then another word to use is annular or discoid. So you classically see that in the discoid lesion of tinea corporis. Next slide. Okay, communicating color. We've mentioned erythema before. Redness, which blanches on pressure. Purpura, so that's a red or purple color which doesn't really blanch on pressure. Hypopigmentation and depigmentation would be areas of paler skin or areas which do not have any melanin. And hyperpigmentation would be areas of darker skin. So I've got some hyperpigmentation at the bottom there. So that would be post-inflammatory hyperpigmentation in someone who's actually just had some discoid eczema. You can see there the annular discoid shapes. Yeah, next slide. Yeah, that's the end of my presentation.